are live on Facebook. Good evening, Endometriosis Summit Facebook crowd and our crowd here on Zoom. We are so excited to have you here tonight for our discussion on painful sex. We're going to go around and everybody is going to introduce themselves, how they are affiliated with the Endo Summit, and also their preferred pronouns. Well, welcome. We'll have Dr. Iris Orbuch introduce yourself first. Or maybe not.
Sorry about that. I'm Iris Orbuch. I'm a she, her, and I love working with all of these panelists and collaborating and just being part of a whole multidisciplinary approach to helping patients get better. And I guess my thing is I love to look at the whole body to help patients get better.
Awesome. I feel like Iris is in the right place. You found your tribe in terms of looking at the whole body tonight. Yes, welcome. Welcome back to our second Endo Summit Live with Dr. Chung. Dr. Chung, can you introduce yourself to everybody?
I'm just so timid. I don't know what to say. Hi, everybody. I'm Maurice Chung. I'm in Akron, Ohio. And I'm glad to be here to see all my old friends. And again, hopefully I can share something with you. I'm a urogynecologist, pelvic pain, MIS surgeon, and I focus on pelvic pain for too many years. I may be like kind of senior now. So I'm so happy to be here to promote the Endo Summit.
Awesome. And to talk painful sex, please welcome for her first Endo Summit Live, Dr. K Ahmed. Dr. Ahmed, can you introduce yourself?
Yes, I am in Manhattan, New York. I work with pelvic rehabilitation medicine, and I've been at the Endometriosis Summit 2 times in person, and was hoping for a 3rd time, but let's see. And I treat pelvic pain in the realm of physiatry. So I'm treating the muscles, the nerves, and the joints, and any musculoskeletal causes of pelvic pain.
Awesome. Welcome, welcome. And please welcome our physical therapist extraordinaire for the Endometriosis Summit. Please welcome Niva Herzig. Niva, can you introduce yourself? You gotta unmute.
Am I still on mute?
Yeah, no, now you're good.
Okay, my headphones don't work. My kids took all the items. My name's Niva Herzig. I'm a physical therapist up in northern New Jersey. I have a practice right outside Manhattan that specializes in everything pelvic health. Over the years, I've gotten to know endometriosis as learning so much from Sallie. So this is will be my 3rd Endo Summit, and really excited to be here with everybody and talk about sex always.
We love to talk about sex. Last year, Niva and I did an excellent Endo Summit Sex and Relationships that sits on our YouTube channel if you're looking for more information on that. And I'd also just like to take a moment that in many times in endometriosis, we are talking about painful sex in terms of cisgendered women. And today we're going to be as sensitive to the issue to be as inclusive as possible. But if you need more information or more help, please reach out to anyone that's here. And we will just try to be as inclusive as possible. So let's talk about it. We have a physical therapist, a urogynecologist, an excision, and a physiatrist. Let's hear from each perspective what causes painful sex in the person with endometriosis. Dr. Chung, do you want to begin?
No.
No. Dr. Iris, do you want to begin?
I just want to listen first before I say something.
All right, Dr. Iris, as a surgeon and a gynecologist, why don't you let us know what may cause painful sex in the person with endometriosis?
Okay. So typically what it is are, I think it starts with implants of endometriosis, which perhaps are behind the vagina, behind the cervix, behind the uterus, in the cul-de-sac or the uterosacral ligaments or the pouch of Douglas, lots of different names. And I think when there is any penetration in that area, usually because the implants are pulling the anatomy to the left or to the right or retroverting the uterus, there's pain. But that's sort of the beginning, because if there's pain from the endometriosis lesions, then what happens, there's like a muscular contraction or a squeezing, which I'll let the PTs talk about. And then I think once you've had painful sex or painful penetrations a bunch of times, then the mind comes in it, because anytime you think you're going to have penetrative sex, already there's like a whole body clenching and a tightening. And then like the whole central nervous system starts flaring because there's the endo implants and the tight muscles. And then the mind maybe becoming more anxious that you're going to experience pain. And what I see a lot also are issues with bladder hypersensitivity that Dr. Chung specializes in, that coexists with the endometriosis. So often it may start with the endo implant, but it's like multi-layered, with each one contributing to pain and each one needing something different to help relieve that that part of the painful sex.
Now, Dr. Ahmed, you are not a gynecologist, but you work with the pelvis constantly. Can you tell us from your perspective what might contribute to painful sex?
Yeah, just like Iris was saying, when people have, painful sex, it could be but the interesting about this is I see men and women. So for anyone who may not necessarily define themselves as a he, she, but still has pain with sex, the muscles are connected, your pelvic floor muscles, they travel between your pubic bone and your tailbone. And if there are muscles that are superficial and there's deep muscles. And so if these muscles are tense or tight from constant clenching, from pain, from, whether it's endometriosis or not, they're gonna cause problems. And just like women who have vaginismus and uncontrollable contractions of those muscles, I find that women with endometriosis tend to have tighter muscles than women who don't, because it's just years and years of constant clenching in their abdomen, their core, their adductors, all the muscles that are connected to their pelvis.
Yes, so very true. Niva, what do you think contributes to painful sex in the person with endometriosis?
So I look at it really by where I'm seeing them in their journey. If I'm lucky enough to see them in the beginning. So actually right now I just started working with somebody who is in high school. The diagnosis hasn't been fully made, but the assumption is very close to, and if not, it's probably likable. So part of it is already where their story and what maybe trauma they've gone through, how many health professionals and physicians or other physical therapists they've seen, some of the diagnoses they've been given, whether they're correct or incorrect. And then I look at their orthopedic background. Is there also something going on with their back, with their hips, any other issues on top of endometriosis itself? And then as Iris and Ty both had said, that the nervous system becomes upregulated, and then we start having these associations. Well, the periods are painful, and now it's the week before my period, and now it's the week after, and now it's the month long, and now it's the constant, and now your body's fighting all the time. And I make this analogy: if I came at you with a knife all day long, every day, 24/7, or even if there's some break, you're going to start guarding. And so now the muscles are upregulating and overreacting and overactive, and the fascia around them becomes as well just tightened, and the blood flow reduces, and we just get into this spiral, and then you have these stories of, oh, they told me I have interstitial cystitis, they told me I'm, you know, not relaxing, and it just becomes this just jungle of mishmash that just takes over.
Yeah.
Okay.
He's
Now-
ready to comment, Pete. He's
Yeah.
ready to comment.
My turn.
Well, you know, you know, in the beginning of my career, you know, I focused on endometriosis, and then I learned a little bit about interstitial cystitis. And the more I learn, the more I don't know. But one thing I do know is the pelvis is a neural network. The question in the beginning was, does endometriosis causing dyspareunia? Yes, no, maybe, because endometriosis may be the instigator that goes along with whether the patient have any underlying neurological issue. I'm using the neurological means that there could be prior pelvic trauma, such as a fall hitting the back of the sacrum, or the, well, the, whatever the area, the crotch, what do you say, the, down that area. I'm the only male panelist here, so excuse me.
Well, Dr.
So-
Vidalia was called into the
I
OR.
know, whatever that you call. And many of those had injuries before, or the childbirth, or sexual abuse, which is one of the biggest things for patients with painful sex. And if you don't ask that question, you never know whether they have been sexually abused. So that set the prior for, if it's a dysmenorrhea, then you have nerve that upregulated. And if our brain, the central nervous system, doesn't know how to control it, and then if you have interstitial cystitis on top of that, you have 2 minus. And if you have injury, you get 3. And if you have a bowel problem, then you get 4. And then if you have prior surgery, if you have abdominal, like C-section, you get some of the abdominal nerve, like the ilioinguinal and genitofemoral nerve affected, then it added more of the pain. So I found that after that many years, I got to treat them all. And the endometriosis may be or maybe not. And I have found patients with so much pain, and I took care of the pain. Then I follow up with laparoscopy. There's no endometriosis. I really sworn by that. I thought they have, but they don't. So it's I call that pelvic neuralgia. Yeah, and it's everything connected, especially the bladder and the muscles. Patient that I see that almost all of them have pelvic floor dysfunctions, the muscle spasm. That's my take now.
Yeah, let's talk, Dr. Orbuch, Dr. Chung. Let's talk a little bit about that bladder connection to the, first of all, before we go any further forward, I should let Dr. Ahmed and Niva discuss what is the pelvic floor, because we assume, being who we are, that everybody just knows the pelvic floor. But let's take it back to basics. And do you guys want to explain what the pelvic floor is?
So the pelvic floor travels between the pubic bone and the tailbone like a hammock, and it holds up your bladder, your uterus, and your descending colon. They all run through the pelvic floor. So when the pelvic floor muscles are squished like this, then all of the little holes that go through it are kind of squished like that. And then it can cause some people chronic constipation, urinary frequency and urgency, and painful sex. And that's just a very basic definition. Niva?
Yeah, as PTs, we're also looking at them. If you want, I actually have my pelvic model right next to me, since this is virtual.
Please show. I mean, to
the
download.
It
from
falls
Pelvic
apart though.
Guru,
I am
didn't.
kind of embarrassed. Yeah, see, look, like the screws aren't.
Well,
good.
at the Endo
But
Summit, we
here's
all
our
fall
thing.
apart.
Right, that's good. So this is our pelvis, the bony parts, making the pelvis and to the spine. And if we lay the pelvis down, we start seeing, see, she's kind of crooked. There's different layers, and I like the that analogy of having the layers. I think people get to understand a little bit that it's not just one muscle, there's multiple muscles. If we turn it upside down, we see the deeper muscles. So, you know, it really depends sometimes where their symptoms are and which layer we're going to treat. Usually that outer layer is that first defense. So if that layer is not happy, there is no penetration. And then we go further in. And as Dr. Ahmed said, like if everything is kind of, you're always just, you know, tightened and squished and mushed and tense and it's not going to feel great.
No, not at all. So Dr. Orbuch and Dr. Chung, what is the role of the bladder in making everything inside your pelvis very much like this?
Maurice, I'll let you feel this.
Really?
I know. I'm not trying to take away all the time. The bladder have Neuro network. The abdominal, like T10 and down, and in the pelvis, that is the S2, 3, and 4 neural network that innervate the bladder. Besides that, the vagina is so much connected to the bladder, especially the trigone area. Many times we examine patients and thought that they might have a myofascial pain of the pelvis because we're examining patient in the vagina. And if you put your finger through the anus, you touch those muscles and they don't hurt. But as soon as you switch it and you touch it through the vagina, and they started to hurt. So the bladder has S2, 3, 4 connection from the sacrum, also from the hypogastric, from the T12, 10, 12, and down. So that is the biggest organ of the pelvis, not the muscle, not the bowel, not the uterus or ovary, it's the bladder. Because the bladder, if you stretch it up, it could be about a liter. So what organs in the pelvis can reach a liter? So there's so much neural network intricating and forming all these connections, especially to the sacrum. So that's why I can say that the bladder has the most neural network and is the biggest organ in the pelvis.
Dr. Orbuch, all these people out there are saying this is a painful sex and endometriosis conversation. Why are we sidetracking into the bladder? Can you talk a little bit about that connection to the bladder and endometriosis? I mean, I know we're in bladder endometriosis royalty, but can you share with us, Dr. Orbuch, a little bit about the bladder and endometriosis and why that may be the source of your painful sex?
Yeah. So when a patient reveals to me that they have painful sex, I always ask them, is it an insertion? Is it deeper penetration? Is it post-sex? Does it last minutes, hours, days post-sex? And then describing how it feels, as well as asking them all sorts of questions like urinary frequency, urgency, getting up at nighttime to urinate. But what I find is that the endometriosis of painful sex is the deeper penetration. Like they'll say, my partner hits a wall, or my partner hits something, or my partner says they feel something hard and I have to make them stop. Like that's like the endo pain. The initial muscular pain, if it's external, I find it's more on entry. It also could be vulvar and hormonal things also, but I find more like the entry stuff. Whereas the interstitial cystitis, or I kind of like to call it bladder hypersensitivity, or whatever we want to call it, painful bladder syndrome, I find that that's more pain post-sex. Like the patients will say, I had sex and I'm in pain for hours, for days, and I can't function. So, and it's interesting because typically I never jump to operate on my patients. I really try and down-regulate all the different reasons why they have pain. And if I think they have bladder issues like interstitial cystitis, they'll report that those post-sex symptoms improve. Whereas if we do that and they still have deeper painful sex, and then we get to the point where I'm operating on them and excising or cutting out the endo, then that deeper painful sex gets better. So, and then once they start doing PT, that external entry pain becomes better. So I don't know if that answers your question with the painful sex and like the differences between the
It
etiology.
does. That's excellent. So we typically think that pain at initial penetration or pain at the beginning is pelvic floor. But pain further back very much could be endometriosis. And I find it fascinating that you say pain after sex for many, many days can be also some from the bladder. What do we think? We got a pre-question before we came on the air. What about pain with orgasm? How do we approach that? And how, what do we think that could be from?
Pudendal
Yeah.
Pudendal neuralgia?
Yeah. It's pudendal neuralgia. And that's my personal experience, of course, to trying to do a study about that is so difficult. But, even though it's anecdotal, but it works. Patient will tell you a couple of things: orgasmic pain, urinary incontinence during orgasm, and deep penetration pain. You're hitting certain spot, they just jump because that's the issue spine. If you touch it, it hurts. If you somehow, then you can even ask some question. So you kind of turn your position, do it in a different style, and would that help? Yes, if you have left pudendal neuralgia, you turn the patient maybe lying on the left side, and when you have intercourse, then it may not hurt as much if it's on the left. And then the other way around, if it's a right pudendal neuralgia, you turn the other side. But usually they're all together. It's not like one side's worse, the other side not as bad, but still, they still hurt. So that becomes the deep one. The external opening, which is the cavernosus muscles and all that, it's the pelvic floor, but it could still be pudendal nerve because the external branch of the pudendal nerve innervate those areas. And you could have injury on the external, such as the bicycle straddle injury, and that's the type. So they have this peroneal there. And I told my patient, the vagina is the big house. The attic is the bladder. The bottom is your rectum. And the back door is the uterus. And the sides are all the muscles. So intercourse is hitting every single thing. So no matter which you hit, you don't even know where you're hitting. You're hitting the bladder, the muscle, the back door, and the bottom. So the dyspareunia is, again, it could be multiple symptoms within the vagina. And I treat it as I have to sort it out which is which and which is which, because they're all connected. I cannot just treat one course, one reason. That's
excellent. So Dr. Ahmed, you were briefly gone for a minute, but now you're back. And we're talking about pain with orgasm. What do you like to tell your patients who come to you with pain with orgasm?
So I try to explain what an orgasm is. It's a whole bunch of little itty bitty contractions happening in like 20 seconds. And when the muscles are really tight, the muscles aren't really getting a chance to fully relax before. So that typically causes more pain. So when muscles are relaxed, then they have an orgasm, that they can actually not have pain during that orgasm. So it makes a huge difference relaxing those muscles. We try different things for that. So, I mean, obviously with physical therapy, sometimes I'll have patients use a suppository, like a muscle relaxant suppository before intercourse, to have a better time.
Yes. So I wonder, Dr. Orbuch, do you think adenomyosis plays a role in pain with orgasm?
I think everything's so complicated because the way that all the different generators of pain come into the central nervous system and the spinal cord, and how all of our pain is being processed, that even if we're not irritating, like let's say if someone's has endometriosis, that flares the central nervous system. If someone has adenomyosis, that flares the central nervous system. If someone has pelvic floor tight muscles, that as well flares the central nervous system. If someone has anxiety or depression or trauma, that as well activates and flares the central nervous system. So the thing is, if we're, for instance, having a tight muscle flare, we may feel it because of the way that it's being processed. It's hard to differentiate. That may flare some of the symptoms from adenomyosis or some of the symptoms from endometriosis, or much the same. I have so many patients, particularly now during COVID, saying, my anxiety is so bad, I don't understand why my pelvic pain is getting worse. I mean, it could be because we're physically tightening, because we're anxious, or our muscles are tightening, but the brain is flaring the central nervous system, which is then processing and flaring the rest of all of those pain generators. So it's really hard to say. And well, I think that if we're pushing on the uterus, which is filled with adeno during sex or then orgasm, that could flare as well. I think it's hard to tease it out exactly which one.
Right. So most of the patients will tease out, they have pain perhaps with uterine orgasm, but they don't have pain with clitoral orgasm. Can anybody, even Niva, just pipe in, can we speak a little bit about why you might have pain with one and not the other? Niva, do you want to start and let us know, and then we'll move on to some of the other answers?
You're asking between
lots of patients say I'm fine with clitoral orgasm and I have pain with uterine orgasm, and lots of patients say the reverse, that uterine orgasm is fine but clitoral orgasm is really painful. What could be this? I know we're not, I could teach a 3-year course in this. We're just scratching the surface tonight. So could we talk a little bit about?
So yeah, I mean, it could, what Dr. Chung was saying, it depends on nerves. So you could have the clitoral branch being a little bit more irritated or less irritated, let's say. But let's talk about the restrictions and the fascial restrictions and the blood flow. And you're asking Iris about that endometriosis, but we're talking about a restricted uterus because of some disease, or externally outside because of the endo. And now, any sort of penetration may try to kind of jostle that uterus, but that uterus doesn't want to go anywhere. So that would be a more internal, and then vice versa. If there's any clitoral, any fascial adhesions to more the urogenital muscles, and again, going back to the nerves, which part of the nerve could be irritated? Is it the pudendal nerve? What if it's genitofemoral? So that might be a little bit more external.
I also add that a lot of people, and Dr. Chung flat out talked about the spine when we began the discussion, but a lot of people seeking physical therapy care, they think it's all about the internal therapy. And what they don't realize is that mobilization of the spine and the sacrum could go almost as far as internal work. So is it that T10 is a little gummy, or L5 is not working the way it should? And is that a part of your pain during sex? Dr. Ahmed, do you see a lot of people complain about whether or not they have pain with one type of orgasm but not the other, and what kind of advice do you give them?
I mean, with endometriosis more, I mean, I do see a lot of clitoral pain, but I see that not so much in endometriosis patients as much. I feel like with endo patients, there is such a difficulty entering. So that muscular component creates a little bit of trauma with internal, uterine orgasm versus clitoral. The clitoral orgasms, pain with orgasms, are usually with people who've had trauma secondary to childbirth, or any injury to the pudendal nerve, and the dorsal nerve of the clitoris particularly.
I always like to point out that, and people come to me when I'm treating, and not just taking care of my parents, but that, is your clitoral pain truly clitoral pain, or is it just to the right or just to the left of that? Because those are two different nerves. So smack dab on the clitoris is one nerve, and then just to the right and just to the left, are two different nerves, and is that the source of your pain? Are you having leg pain and what you're calling clitoral pain because you're aggravating the genital branch of the genitofemoral nerve or the ilioinguinal nerve, and that's contributing to leg pain and what you're calling clitoral pain, but it's really to the right or left? So when I see a patient, I actually map it with a grease pen. So I can see, I actually map every little bit out, and then I send them to Dr. Ahmed or anybody else, but so that we know what is the nerve root of this pain. Dr. Chung, why might somebody have pain with one type of orgasm, but not with another? Like Dr. Chung is so excited he's the only male here tonight. I mean, he just thinks this is great, right?
Well, I'm hearing all these sexual things for too many years, and I'm not going to give up some of those unbelievable stories. There's one, I'll go back to one question you asked before, endometriosis. I've done a study in 2007. I have 100 patients that have surgery. 50% of them have endometriosis on the pathology, 50% did not. And of the 50% of those who have endometriosis, 50% have pain and 50% did not. And those 50%, those who have pain, and I did test them for the bladder, and 85% of those patients with endometriosis and have pain have a painful bladder. So I can only say that is, we weren't taught very well on that, did not know how to approach, just assume that what you see, the I see, you see, you don't see it, I see, but what you see may not be what it is.
I
So,
pay him for that.
Yeah. So that's one part. Now you talk about different type of orgasm and have different pain. Well, it's all neuropathology, I assume, because there are some patients, just like Sallie was saying, I agree with it very much, that the doctor were not taught how to evaluate them. Did not even know how to use a Q-tip or little toothpick to sort out the neuropathology of the pelvis and find out whether there is a pre-existing pudendal nerve injury, the branches or clitoral branches or labial branches, or the deep one, which is the deep pudendal nerve or the pelvic floor injury with the pelvic muscles. So I suppose that if you have external orgasm, if you, let's say the word masturbation, and may give you the different type of pain if the patient have the clitoral pain, whereas the other, when you have deep penetration and hitting certain different nerve plexus, have different pain. And so we don't forget the ilioinguinal genitofemoral nerve innervate the bladder and also onto the pudendal nerve refer pain. So it is just too complicated. It's the pain mapping that we all need to learn well to sort out all the area. Coccydynia causing the entrance pain too. So that's the injury of the coccyx.
Very
I think
interesting.
also there's such crosstalk in that area. You know, a lot of patients don't really, for a long time, don't understand, or they feel all this bladder pressure, let's say, or urgency or discomfort, right? But then they're unable to differentiate that between clitoral and bladder, and sometimes even coccyx. So if there's such a, like the highways, there's too many entries in the highway, you know?
Or I think it's the torrential rain, all the branches for the river is completely open. You just never know which is what.
We have a question about pain with arousal. Dr. Orbuch, I know he just thinks this is great. So Dr. Orbuch, I wonder, what do you have to share with us about pain with arousal?
Wow, not very much. I wish I knew more. But one thing I do want to throw in about the last topic, and then I'll let someone else field that question, is something that I've realized a lot over the last, let's say, 4 or 5 years, is the role of low testosterone on the vulva. And because so many young patients or older patients in general who have painful periods or painful sex, the first, like the knee-jerk reaction of a gynecologist is take birth control pills. And we know that lowers the testosterone level. And I've collaborated with someone out here who who does a lot of topical estradiol, testosterone. And it is amazing in how short order, by sort of bulking up the vulva, that may change some of the vulvar symptoms or some of the external symptoms that then can help us to elucidate what actually is causing the pain. But I just wanted to throw that out there for anyone on birth control pills, that the low testosterone is very important to address.
Right.
Well.
So I'll also, not that we need to know this much about me on Facebook Live, but I also will say I had significant ilioinguinal dysfunction in my genitals, and I did everything on earth. I did everything right. Obviously, I have access to like great care. And it wasn't until I started to use topical hormones by a specialist who knew to put a little testosterone and estrogen in the mix that the injury began to heal.
Yeah.
So it's very important what Dr. Orbuch is saying right now. Yeah.
It's amazing because when I was in New York primarily practicing, I feel like I didn't have that piece. And when I came out to Los Angeles, one of the physical therapists who I worked with, one of our first collaborative patients, she said, listen, I really think she would benefit from, estradiol and testosterone. She's like, would you write the prescription? I'm like, I have no idea what to write, but I'd be happy to write it if you can educate me. And it is amazing how beneficial it is for those who are symptomatic because of the low testosterone.
Right. And I think
thank you for
doctors
having that conversation with that PT too, Dr. Orbuch.
Yeah.
Oh,
I think
That's
doctors are really
part of the
hesitant.
toughest part.
yeah.
They're hesitant to let you try it, but patients, you can do anything behind your doctor's back. So I'm curious, let's talk about leg pain and painful sex. Dr. Ahmed, do patients complain that they have leg pain from sex ever to you?
I mean, I hear about leg pain all the time, referred pain from the pelvic floor, but not particularly during intercourse.
So we have a question from the crowd that says they have horrible leg pain after sex each and every time. Dr. Chung has released an amazing study, but I was giving everybody a chance. Dr. Chung, do you want to talk a little bit about leg pain and painful sex?
Well, there are two things. I think the previous questions about pain on arousal and then leg pain. Now, let's say pain on arousal, if it's external, it's all the same thing, S2, 3, and 4. If there were any prior injury to those nerve root, so it depends on which one was affected. So when you are stimulated, the one that's already hyperstimulated is gonna become uncomfortable and hence pain. Leg pain during sex is the same thing because of the nerve connections in the deep pelvis. S2, 3, 4, leg pain, sciatic, S1. So they are connected in the pelvis. So they just, I think the pelvis gossip too much. Whatever that is, either go up or down. And when I do all these pelvic block, the leg pain went away. So if I were to answer that question, yes, I have a couple of patients, they're all better. The back pain gets better because it's all crosstalk. Neuro crosstalk. So if the leg pain get to be painful, well, you have to ask which side. Why is it one side worse than the other, not both sides? So you have to know there got to be some type of neurological insult or muscle insult on that particular area that make it travel down the leg. Again, it's the pudendal nerve that give you orgasm. So anything you can blame that, which I have too many of those. Patients come into my practice say, I just felt that I have orgasm the whole day. It just drives me nuts. I said, oh, okay. Some patients wish that, but you are having too much. So ultimately, I give them the pelvic pudendal block. It's gone.
Yeah, I think the pudendal nerve gets blamed for way too much. I think there are so many other nerves in the pelvis.
Yeah, there are so many other nerves. But
yeah,
whatever I'm saying is, we don't know. You can only try and fix it up. You give the injection, it disappears, And then the patient would complain the other way around. Now it takes me forever. I said, oh, I'm so sorry. I just don't know how to deal with it. I take away your unwanted, but that also take away some of those. It may come back to normal with time. The pudendal nerve, I don't call that pudendal nerve anymore because the injection doesn't cover just the pudendal nerve. It covers a lot of the pelvic floor muscles. So I think it's the combinations.
So Dr. Ahmed, we have a very interesting question from the crowd in what can someone do to improve neuro crosstalk and help them have less painful sex? I think the physiatrist is a great person to answer this.
So, I mean, we want to treat the CNS and the PNS. So if we're going to treat the PNS, we're always using physical therapy, our favorites.
Peripheral nervous system, so everybody knows what that is.
So we'll refer to physical therapy. We'll try different suppositories, depending on whether you're clear to use dilators. Dilators can also help with stretching and desensitizing. We might use oral nerve medications to work on the central nervous system. Depending on whether there is concomitant anxiety or depression. It's really, there's so many different categories of medications. I love creams also. Typically I'll use, if someone doesn't want to take oral medications, I might try a bunch of different versions of it in cream form. And then, meditation, yoga to work on the CNS as well, without, to kind of remind our brains what it's like not to be in pain all the time. With intercourse, I typically tell my patients to not try to have intercourse unless they think it's going to be a successful intercourse, if they're looking for penetrative intercourse. So don't jump the gun if you're on dilator 1 and now you're going to try to have sex with a partner who might be dilator 7 size. That creates a lot of negative energy and negative feelings towards intercourse. So don't mess up the crosstalks by adding more trauma to it. But a lot of times patients will be working with their therapist, and then their therapist may say, okay, I think this is a good time to try. We've worked on a lot of the anxiety, a lot of the nerve issues, and then at that point they can try and see if they're successful. And just because penetrative intercourse is not necessarily achievable or successful on the first few tries doesn't mean that there isn't other stuff that they can do.
Right. So Niva, what do you like to say? The person had horrible, painful sex their whole life. They ended up having endometriosis, and they've done a good excision, and then they've done a course of physical therapy. How do you like to walk them back into having pleasurable activity and knowing when it's time for them to have sex again?
So a few different ways. One is I invite them to create a safe space for them, whether it's in their home, wherever they are, with a partner, without a partner. I like to use a guided visualization, even without the dilator. What do they want an insertion to look like, if that's what they're looking for, penetration? What do they want any of their sexuality to look like? Do you want to have some music on? Do you want the lights on, the lights off? So again, anything that's going to create that safety. So that's, again, for their central nervous system. As far as I've kind of figured out that usually somewhere in between the medium and the larger dilators for most people, if they haven't attempted anything penetrative, then I usually give them a go ahead once they feel pretty comfortable at that point. But again, I got to clear out sacral mobility, spine mobility, and hip mobility, because they'll also play a part in that aspect of penetration and sex.
So I wonder, Dr. Ahmed and also Niva, I shy away from having patients use dilators because I feel like that's a very medicalization of the pelvis. I know during the pandemic, we did switch to the intimate rose wand because not everybody can get access to a pelvic PT now. But most of if not all, and if they're willing to admit it, most of my patients have toys now. And so how do you, I feel like as a pelvic PT that sometimes incorporating the toys, that has already that pleasurable sensation to the person's central nervous system and brain. And so oftentimes it's easier to coach them back into having sex by letting them involve that rather than involve the dilator. How do you think that that plays a role in the work that you do with people?
Yeah, so I mean, first,
Any
ask them
minute,
what they
Facebook's
want.
shutting us down, by the way. Any minute, we're going to get censored. No, but it's fine. Keep going.
I won't use terms, but I asked them, what do they want? I mean, I offer them, you can use something like a dilator, but a toy, anything. And if they say, oh yeah, I already have X, Y, and Z, you know, I ask to see it. If I think that, like what Dr. Ahmed was saying, you know, if they show me something it's a size 7 that I, you know, it looks like a size 7 dilator and they're just coming into me, I might say, okay, maybe we should either get a smaller toy or let's try this. But that's the whole point. Give them the power, you know, let them create part of their plan, because that's how they're going to get into healing. If I tell them what to do, if I say, you're going to do this, this, and this, and this is what's going to make them better, A, they're going to rely on me forever. B, if I don't get them to where they are, it's my fault. And C, where's their power? And they've lost so much power in this journey anyway. So it's about them. Go for it, whatever you want to do. And it's a variety of things too, right? Why does it have to be a standard looking dilator?
Right. So we have a question. What about, and it was sent to us earlier today, and I want to make sure we get to it. What about somebody who was diagnosed with endometriosis, possibly for maybe silent endometriosis for fertility, and they never had any painful sex before surgery? And now they've had a surgery, and after surgery, they have horrible, painful sex. What do we, I mean, there are so many things. We have a whole panel of professionals that could talk to us about what could be going on. But Dr. Orbuch, where would you start with that patient? Patient has never had painful sex, has excision, comes back to you with painful sex. Where would you start in terms of working with that patient, aside from physical therapy?
Yeah, first I would just have to get a good history. Is the pain on entry? Is it deeper penetration? Is it a certain spot? Is it afterwards? And then for me, my physical exam is the most helpful at helping me figure out where to go with the particular patient to achieve their goals. So if I examine them and well, first of all, let me just say, sometimes I find that, well, there could be adhesions, there could have been tight muscles that they didn't realize. So you can palpate the tight muscles. Does that reproduce pain? We can push on their uterus. If that reproduces their pain, then maybe it's adeno. Were they stimulated a bunch because of their infertility? I definitely do find after lots of stimulation that can rev up.
IVF stimulation, not stimulation.
No, not stimulation, right. IVF stimulation. So I'd have to have a better history, and then I would do a very detailed and thorough physical exam and let my physical exam guide me.
Right. So I told our viewer that asked me this question this afternoon that, you know, sometimes during surgery, they're using the Pelosi that can upregulate somebody's pelvic floor, right? Mm-hmm. And then the other thing is, did the position, not everybody is using somebody who is fantastic at positioning like Dr. Orbuch or Dr. Chung. Did the position that you were in during surgery put tension on your hips or your sacrum? Did recovering from surgery and trying to get out of the hospital the same day put stress on your pelvic floor, your abdominal wall, or your spine? Did the and then of course, you know, if it's a fertility patient, did any of the IVFs contribute to that? Dr. Ahmed, somebody who had pain, who has pain post excision of endometriosis with sex, where do you like to begin with them?
I mean, it's kind of where I begin with everyone, except now I don't have to do a whole endometriosis workup. It's going to be similar to, you know, patients basically trying to figure out what's going on, whether they might have already had pain with intercourse and weren't able to recognize it in the past. because sometimes they thought that was normal, or, you know, if we delve back into the history and they say they did actually have pain with tampon use in the past, and maybe they didn't recognize it before. But then we basically are going to start, I would think now it's okay to use dilators, especially now that they've had a proper excision at this point. And then maybe we'd start off with some suppositories. We might do some trigger point nerve block injections in their pelvic floor to help speed things along, depending on, you know, what their ultimate goal is. If they're in a relationship where there's one partner versus multiple partners, we might, you know, have them doing dilators and or toys, depending on what they have and feel most comfortable with.
Awesome. So what do we think Dr. Chung, did you have anything to add? I see you nodding by your tree there.
I think they all talk about the right thing. I have too many of those coming to me for post-surgical pain. And very true, you have to go back to ask whether they have some of those symptoms before. Endometriosis surgery depends on how you do them. You burn them, you cut them, you create neuroinflammation of the pelvis. Again, if the nerve was already unsettled, then you can send them off the roof. And there's always a sentinel event of everything. Some patient with pain, oh, I didn't have any problem. I have a colonoscopy, then everything started to hurt. Oh, I have my LEAP procedure, then everything started to hurt. So if you do laparoscopic surgery, you have a uterine manipulator, you go left and right and up and down, and you just jerking the pelvis too much, and you may set the bladder on fire too. So many of these pain, I treat them as, it doesn't matter whether it's before and after, I still go through my algorithm and to sort them out from one to the other. And usually they get better because it's something that we missed before, or the doctor who did the surgery and did not even ask those questions before.
Right, and don't forget to do surgery. People are putting in a catheter. So that's going to fire up not only the inside of your bladder, but all the neurons around your bladder. So we're starting to wrap up tonight. One of the things that I want to ask, and I'm going to have each panelist answer, is what do you think are some of the barriers to people getting help with their painful sex? Because we joined here tonight with an open mind and no filter, but not everybody is the same way. So we'll start with you, Dr. Orbuch. What do you think is some of the barriers to people getting help with painful sex?
I think one of the biggest barriers is, there's two, it being a taboo subject. So people not even speaking up about their painful sex, or they always had painful sex, so they just think it's normal, or being dismissed by a gynecologist who says, you know, have a glass of wine and it won't be painful. So you're so like beaten down, you don't even want to bring it up to someone else. So that's a huge barrier, that, and then the lack of proper knowledge by general gynecologists, like not being able to help someone who finally does have the courage to speak up. That's a huge, that whole aspect. There's a financial component just to the cost of therapy and physical therapy. And I think those are two of the bigger issues.
Yes, Dr. Chung, what do you think are part of some, you know, you've been teaching worldwide for so many years. What do you think are some of the barriers around the world towards people getting help with painful sex?
The culture, just like Dr. Orbuch was talking about, women doesn't necessarily want to come forward to tell you the truth if you don't ask them. Now the culture, like what she said, and plus there's one thing, and they don't want to disappoint the spouse too. If those all come together in the exam, and sometimes they don't want to talk about it, and they would just deny it until when you examine them, they hurt. There's no reason that just a little finger touch would send them off the roof. And I said, well, you said that you don't have painful sex. Now I'm just touching like this little, then you hurt so much. Then they said, oh yeah, it hurts sometimes, but it just be a quick one. So there's a lot of those that's been going on. It just how the clinicians or the healthcare provider can kind of fish it out from how to ask the right questions. I think that's very important. Not too many of those will tell you they have painful sex, even though they come in for pelvic pain and you ask them, do you have painful sex? Oh, I don't. That had happened before. So I think it's the culture. That's the big part of it. Of course, that they're not going to tell a male physician I have painful sex. That
Well,
easy.
Well, now we baptized you. Everybody's going to tell you everything after tonight. After tonight, you can tell Dr. Chung anything. Niva, what do you think are some of the barriers to someone with painful sex seeking care and getting care?
Embarrassment, shame, and feeling alone multiple times a week. Do you have anybody like me? Do you have anybody like me? Have you seen me? You know, finding the right care, having specialists, for sure, specialists that understand endometriosis and have treated endometriosis. I don't think I have a problem having people tell me that this is part of their issue. So I think if you know how to ask the right questions, and if they are scared, these questions are all in my questionnaire. So if they don't want to, and actually when I've expanded my questionnaire recently after taking a course for cisgender male, and in fact, I expanded my questions a little bit more specifically on sexuality. And the responses have been great. And it's actually much easier for me to ask them questions in the office. But I think fear, shame, and trauma in the past, trauma by the healthcare society, by being dismissed, telling that you're crazy, nothing's wrong, things like that.
Right. We do have a comment from someone from the LGBTQ community right now talking about how they hide who their partner is. They hide the gender of their partner a lot of times to the healthcare professional. And we could do a whole live on this, because if anyone ever were to know the gender of their partner, they wouldn't take their pain with sex seriously. And while we all do, that we have to realize that unfortunately that needs to change in primary care and in gynecology. I took, for those of you that follow Endo Queer, Les Henderson is amazing. And when I met Les, the first thing that was said to me was that they were told to switch teams and then all their endometriosis pain would go away. And let me tell you, that was within the past few years. That wasn't like, oh, years ago, somebody said this to me. And so I think a lot of, in LGBTQ, people are scared. They're gaslit. We're all gaslit with painful sex and with endometriosis. That in that community, the gaslighting is a whole different animal. And we're coming into awareness of that, and we're working hard to change that as we can. Dr. Ahmed, what do you think some of the barriers to seeking care for painful sex are?
Well, number one, probably, depending on the person, but the culture, the taboo, religion, how they were brought up, what type of background, whether their parents were strict or not, whether that's something that they can even speak about. I have plenty of patients who are, embarrassed to tell me about their first sexual encounter, about the age, about because they may feel like that, someone would judge them. I will, if you ask anybody who knows me, like from growing up, they're always shocked that I'm always talking about sex, because I was definitely not someone who was walking around talking about sex in my teens or 20s. So it's very interesting talking to people and trying to make people feel comfortable. So they really need to have that amount of time with the provider to speak with them, because you're not going to tell a doctor you were going to see. I mean, when I go to my gynecologist, I see her for 7 minutes. I timed it. It was 7 minutes door to door. So I'm not going to tell her anything in 7 minutes. You know, I'm going to say, yeah, I feel fine. Just do the PAP and you're out. Second, a lot of patients, similar to cancer patients, feel like if I don't have cancer and I'm treated with cancer, then I should just be lucky I'm alive. I think a lot of endo patients feel like if my abdominal, endo pain or, cramping is improved, or my period pain is better, then I should just be lucky that I'm okay and I don't need to worry about my pain with sex, even though that is like a major part of their endometriosis. So sometimes I think they just maybe feel they don't deserve to have pain-free sex, which obviously everybody deserves to have that.
Everybody deserves pleasure. And I think so many people, including myself, the first time they go to a doctor, perhaps in their young, as a teen or in their young 20s, the nurse practitioner or whoever is seeing them will say, did you try wine? How about some meditation? Did you just relax? I don't think just relaxing is going to fix the neuromodulation, is going to fix your pelvic floor, is going to remove a deposit of endometriosis from you. And then I think people are taught to be quiet about that pain. And so I hope that moving forward, we challenge everybody to have a discussion like we had tonight that educates people on the causes of painful sex and that embraces that it's okay to ask these questions. For anyone who does not know, Endometriosis Summit tickets are on sale. We have pre-sale on sale. So that's the 3-day pass for Endo Summit surgery, Endo Summit workshop, and our patient and practitioner town meeting. And everybody who spoke here tonight is presenting in one way or another. Dr. Ahmed will join us in the town meeting to talk about painful sex with Dr. Jessica Apoku Anane, who I think is on the program for next week. Next week, we will be talking adhesions with Dr. John DeLumba and Dr. Patrick Young, who has introduced a technique for adhesions and fertility. And I believe Dr. Apoku Anane has signed up as well. So I hope you pre-sale. That 3-day pass is on sale just for 1 more week. After that, we'll have tickets to each individual day, which may be a better price point for you. And we look forward to further discussions about painful sex. And thank you everybody for joining us. Thank you, Dr. Chung, Dr. Orbuch, Niva, Dr. Ahmed. It was fantastic to see you, and we'll be back at you next Monday night. Take care.
Thank you.
Bye.
Bye.
Bye.